thought it was going to be really cool, and I thought I'd be able to do something with it. But what I did have anxiety about was whether I was going to be able to make it into a thesis. And in fact, those anxieties stuck with me for the full 3 years.
Welcome to the sOOPR podcast, designed for medical trainees looking to take time out of training for a clinical research fellowship in the UK. Each week, we'll bring you a 15-minute discussion with a leading expert in the UK medical research process, or from a successful research fellow sharing what they wish they'd known before they'd taken their time out. I'm your host, Nikhil Alawalia, and on behalf of the British Junior Cardiology Association and with support from the BHF Clinical Research Collaborative, we're proud to bring you this series. We're pleased to have today with us Dr. James Howard, who's an NIHR clinical lecturer and cardiology registrar at Imperial College London. In 2017, James undertook a Wellcome Trust PhD training fellowship and was awarded his PhD in 2020. For work entitled Deep Learning Using Convolutional Neural Networks in Clinical Cardiology. James's research work has continued to grow from strength to strength, and recently he presented the findings of the SAMSON trial at the American Heart Association 2020 conference and was published in the New England Journal of Medicine. So welcome, James, and thanks so much for taking the time to join me today and share with us your wisdom.
No, thank you very much for having me.
Great. So, James, if it was okay, I just wanted to start by asking you a little something about your journey so that the listeners could understand where you came from when you came to do your research work. So I understand you were an academic clinical fellow during your registrar training. So from that, is it safe to assume you always were planning on doing a PhD?
Yeah, probably. I mean, I didn't apply for the academic foundation program. It's quite hard to remember what was going through my mind back then, but I don't think research was necessarily on the cards from day zero, because then I probably would have applied. But I remember very much falling in love with academic cardiology and evidence-based medicine in my F1 years. So certainly a while, yeah.
Okay, and do you remember what the exposure was that really got you interested in the academic work?
Yeah, I do actually. I remember when I was on a gastroenterology job, I did a post-take ward round with the cardiology team, and they were just talking to me about eplerenone, which was relatively new, and the evidence base for it. And they were talking about trials. I remember being very impressed that they knew the name of emphasis and ephesus and all these trials. I remember thinking, oh my gosh, how could anyone possibly learn all that? So I Googled about these trials and realized that no one had actually made a list of all the key trials in cardiology. So I thought that would be a fun thing to do. So I set up my website, cardiologytrials.org, where I sort of list the key evidence base. And I started realizing all the amazing nuances in trials. And while there were some trials that seemed very good, but no one paid any attention to, and others which were quite small and quite modest in many ways, but changed the face of cardiology. And I guess I got bitten by the bug then.
You undertook your research work with Professor Darryl Francis, who's incredibly passionate about critical analysis and making it all accessible to the masses in his own unique style. How did you come across working with him? Was it something that you had an explicit conversation where you asked him to be your supervisor, or is it something you stumbled into?
Well, he and I give different answers to this question. What happened was I uploaded my CV to my website at one point. And this was before I met him, and he typed in something, he typed something like Imperial College Heart Failure SPR Competencies into Google, and my CV came up. And he claims on my CV that I was claiming to be a cardiology registrar, despite just being a CMT. That is not true, but he claims that was the case and said that he emailed me basically to tell me, one, stop committing fraud, and two, I see you can write mobile apps. Would you like to work with our group? And interestingly, that mobile app ended up becoming the mobile app we use in the SAMSON trial. But that was actually how we met, rather serendipitously.
Great. So moving forwards then, you got your Wellcome Trust PhD grant, which is a fantastic award, fellowship to get. Can you talk me through a little bit about the thought process and why you applied to the Wellcome Trust?
Yeah, so actually, that wasn't the first PhD fellowship I applied to. A couple of weeks earlier, I'd handed in an application for BHF and MRC fellowships. And for the people that don't know, they're very different. So with BHF and MRC, you apply with your CV, but you also apply with a research plan. So almost like a protocol and several pages of what you're going to do. And you'll have written that with your future supervisor. But Welcome was very different. This was the first year that Welcome changed from that system to being much more like an ACF, in that you do not apply with a project, you apply with your CV and you have an interview, and it's much more about the candidate. So I applied to all three, BHF, MRC and Welcome. And I got the Welcome one first, ended up withdrawing my BHF and MRC ones because Welcome said basically, now I got it, I could do whatever I wanted. And one of their themes was informatics, and I really want to do some work in artificial intelligence. So that's how I ended up going down that route. And for my personal taste, it was perfect, really.
Can you talk us through a little bit about what you had to demonstrate and how much of that was an assessment of you versus an assessment of your project?
Yeah, absolutely. So like I said, I was the first year where it changed this system, and Welcome were very clear about why they'd made this change. They said that they were giving out a lot of CRTFs, clinical research training fellowships, prior to this to candidates that looked exemplary on paper and had exemplary projects, but 5 years later had no intention of continuing their careers in academia, no intention of getting an intermediate research fellowship. And that's going to be the case with a lot of people doing PhDs in cardiology, and there's nothing wrong with that. But Welcome felt that they wanted to try and select people whose were planning on a future career in academic medicine. And they felt they could do this better by removing the project aspect and emphasizing the interview aspect. One of the key things is actually convincing the panel that you, in 6 years' time, will be applying for an intermediate research fellowship.
Was your supervisor supportive of applying for your fellowship with a general theme in mind rather than a clear protocol and timeline?
Darryl Francis really liked the idea because he realized it would give us the flexibility to do what we think is fun. And actually, if Darryl Francis has one weakness, it is probably being sidetracked. So the fact that there's nothing they can hit me over the head for not doing at the end of it, because I never told them what I was going to do in the first place. And I think for a lot of people, the lack of structure may be more of a concern. One thing that's quite good about writing a grant is a lot of the time you'll apply with a kind of Gantt chart and a timeline, and it's very easy to see if you are meeting your kind of key stages in your development. And when you go with the kind of organic, slightly nebulous thing, there is a risk you'll fall through the cracks for the first year, and only then will you go, what am I actually doing? So I think it very much depends on the candidate and how much they feel they need structure.
Do you think this sort of unstructured approach would have fitted into the BHF or MRC application?
BHF and MRC are hard. You really do have to have a plan in mind. Interestingly, once you get it, the funders are usually very receptive to you changing it. So if you've bitten off a bit more than you can chew, they're very sensitive for you redesigning your experiment. But you certainly have to have what sounds doable, what sounds practical, what sounds important. It has to engage patients a lot. So you will always write a lay summary with your PhD. And a lot of places will shortlist based on that lay summary.
I mean, how did you estimate the funding requirements needed if you didn't have a clear vision of what exactly you were going to be doing?
Yeah, so this is very difficult. Costings in PhDs, when you're going to do things like AI, is very tough.
I mean, did you feel a sense of anxiety almost that you were pursuing something that was of interest to you, but back in 2017, there was no way of really being able to guarantee that this was going to result in something of relevance, versus I suppose, the safer option of taking a subject that was physiology based. It would have had significant consequences no matter what. I mean, it seems like a big step to have taken at that time.
Yeah, so actually, I did have some anxieties. I didn't have anxieties that it wasn't going to work or that people weren't interested. I thought it was going to be really cool, and I thought I'd be able to do something with it. But what I did have anxiety about was whether I was going to be able to make it into a thesis. And in fact, those anxieties stuck with me for the full 3 years. even when there only maybe a year left, 6 months left, I did sort of feel that my thesis was going to end up a bit like a fruit salad of cool, fun things I did with AI, and not a single narrative like most people's PhDs are. My thesis ended up 4 different results chapters using neural networks in completely different ways and completely different imaging modalities. And actually, I did manage to tell an interesting story and tie them together, but the unifying thing was the methods I used and not what I examined, which is different from most people's theses. And I was a little bit anxious about that.
Can you just tell me a little bit about how your 3 years broke down? So an overview of what you did in the first year, second and third year?
Yeah, absolutely. So my organization was a bit different from most people's. Like I said, I'd already started working on the pacemaker app before I started. So my priority, the way I did my PhD, was I thought every one of my results chapters, I would really like it to already be a paper when it comes out, because I felt, and it may be naively, that when people are marking my PhD, it makes them much harder to say, this isn't very good or this is irrelevant if I've got it published in a moderately respectable journal.
Sure.
So I did each of my chapters almost sequentially. I did the pacemaker paper, then I moved on to echo. I did the echo paper, then I moved on to MRI. And then in the last year, 6 months, I did the HIS bundle pacing ECG neural network with Aaron. And I did them one after each other, but that is very different from most people's PhD. Most people's PhDs, for example, if it involves patients, they will have a single patient cohort that they are often recruiting, often won't do any recruitment for the first 6 months because they'll be waiting on ethics or trust R&D. Then the door will open. They'll recruit like mad for 2 years. And then with 6 months left, they will say, okay, I've got all my patients, and they will start doing all their analyses, and the different forms of analyses will form different chapters. That is, in my experience, how most of my colleagues' PhDs went, but mine was very different.
And so how much was what you had originally thought you were going to do, how much is that similar with the final result? I mean, how much did this evolve through the journey?
Yeah, good question. So one of the problems with AI is the landscape is changing a lot. And the thing that everyone thinks about AI, and I thought too, were the obvious things. So if you say about AI and echocardiography, what everyone thinks you're going to mean is AI tracing of the left ventricle in the plaques view, AI tracing of the left ventricle in the apical 4 chamber, AI tracing of the left ventricle in the apical 2 chamber, automated Simpsons, and so on. You can do that if you want, but there are about 1,000 research groups in the world doing that, and there are open access data sets. And I knew that I probably wasn't going to get much recognition in the world being the 1,001th person to be doing that. So I ended up devoting my research interest into things that were slightly more niche and people hadn't done before. And I didn't do anything involving LV segmentation in my PhD at all, even though when I first applied with Wellcome, it was actually supposedly going to be the bulk of what I was going to do.
So artificial intelligence has become quite a hot area for a lot of trainees, and I think a lot more prospective fellows will be considering doing their research in this area. Do you have any advice for those trainees about what things could trip them up, or lessons you may have learned during your journey about the challenges working in this sort of non-clinical area of research?
Yeah, absolutely. So I think if you're interested in working in AI as a doctor, there's 2 ways you can do that. The first way, which most people do, is you work as part of a team with computer scientists and engineers, and you are there as the clinician, and you are just as indispensable as any of them. And your job is to emphasize the clinical aspect, maybe to help curate the data, to label the data, to help turn their solution into something that is clinically meaningful. And there's a big role for that. I did do that, but actually I wanted to do AI because I wanted to program. It's been a passion of mine. And the reason I was interested in AI was because I really wanted to train neural networks myself. If you want to do that, you then have to learn an extra skill set. It is not as hard as people think. when people do a basic science PhD, you have to learn how to do Western blots and how to do ELISAs and things like that. Programming is another one of these skills. It comes more naturally to some people than others, just in the same way maths comes more naturally to some people than others. But I've had BSc students and academic foundation doctors who have picked it up. So it's certainly an option.
James, that's been fantastic so far. Are there any final messages you want to leave our listeners?
So the first thing I would say is, do not just assume everyone that does AI is a genius, because actually a lot of the aspects of AI are what we used to call statistics. And a lot of these things are just very logical and can be learned by anyone. So if you're interested in doing it, then do not feel too intimidated.
Once again, thanks very much for your time, James. We really appreciate it and look forward to seeing the results of everything you're doing at the moment. Thanks very much.
Thank you.
Next time on the podcast.
Rejection is a necessary byproduct of the whole process. It's definitely not personal, and it happens to everybody.
In today's episode, I sit down with Dr. Upasana Thayil, who recently completed her PhD in cardiac imaging and the genetics of dilated cardiomyopathy. We discuss rejection during research, how to build resilience, and the change in mindset from clinical medicine versus academia.